Alright, very good. Okay, we are officially live. Looks like we have 3 people watching. If you are online and you have questions, go ahead and type them into the chat section on your page, and I will try to answer them. And we are good to go. Okay. How are we doing, everybody? Just think, we have 4 weeks left. Right? 4 weeks left, 3.5, more or less. Yeah. What is it, the 2nd? Yeah, so 4 weeks. We're going to be halfway in the finals. Pretty good. So you almost made it. So today is our study session for the 4th exam. You saw earlier today I posted this information, otherwise you wouldn't be here. And then also the study guide. So you've had some chance to kind of review the material over the weekend. What questions do you have looking at everything so far? Anything at all?
Can you go over exo and endotoxins?
Yes. Alright, so the question was, can we go over exotoxins and endotoxins? So we'll start off with the shorter one of the two, I think, because we've spent so much time talking about it. Alright, so when you hear endotoxin, what does that translate in your mind to? LPS, very good. So endotoxin, an example of endotoxin, or the other name, the synonym for endotoxin is LPS, or lipopolysaccharide. What was the significance of LPS being an endotoxin? What's that? So it can lead to septic shock, but not always, right? Every time you have a gram-negative infection, you don't go into septic shock. Why? What was that big difference between, let's say, no, not gram-positive and gram-negative? Good guess. No, your body recognizes it. But there's a difference than if I were to get a gram-negative infection, let's say, in my finger, generally speaking, I'm not going to go into septic shock. Why is that? Even though LPS is present and it is an endotoxin, why would I not be going into shock? Very good, very good. The infection would have to go, or the LPS would have to go into the bloodstream. The only way for that LPS to go into the bloodstream, for the most part, would be if the bacterial infection spreads from a localized site of infection, such as my finger, into a systemic infection where it's body-wide. If you have bacteria growing, or not really growing, but contaminating the blood supply, what is that called? That is sepsis. So the definition of sepsis, again, is having an infection of the blood. It doesn't necessarily have to just be bacterial. It could be fungal. It could be a variety of things. But an infection, an active infection of the blood is sepsis, which can lead to septic shock, right? So how do you go from sepsis, bacteria in the blood, to septic shock? What is causing that transition to occur? Anybody remember?
Your body overreacts to LPS.
Very good. Your body reacts, and overreact, I think, is an all right word, because if I have an infection in my finger and I get inflammation in my finger, I'll get swelling and redness and all that fun stuff in a localized spot. But during sepsis, if I were to get inflammation of my bloodstream, which just so happens to be everywhere, that's where you run into the risk of septic shock, because the hallmarks of inflammation are things like redness and swelling, and all of that happens because of inflammation, whereby plasma and sometimes white blood cells leave the bloodstream. And if that's happening all over your body, what's going to happen to your blood pressure? Your blood pressure tanks, you become hypotonic, and that's where you run the risk of going into septic shock. So septic shock is that hypotonic reaction that takes place in response to the sepsis. And again, the problem with being hypotonic is that your organs, particularly your kidneys and your liver, are obscenely sensitive to hypotonic conditions, and you'll go into organ failure. Okay, so that all happens because of endotoxin. And again, the hallmark of that is, are you dealing with a younger clinician or an older clinician will generally decipher which one they're going to say. Older clinicians tend to say endotoxin and toxic shock and endotoxin shock. That's what they're referring to. Younger clinicians just coming out of medical school will generally refer to lipopolysaccharide or LPS. Does that make sense?
Going over that real quick, so the septic shock slide. Number 2, it says TNF causes damage to capillaries resulting in loss of fluid resulting in shock. What is TNF?
Oh, good. So TNF, just to kind of rephrase this or recenter that. So, let's say you do have a bacterial infection of the blood and you have LPS, on that bacteria, your body senses that LPS. When your body senses LPS, this complex reaction we haven't really gone over yet, what happens is your white blood cells, and in some cases your endothelial cells, will produce things called cytokines. Cytokines are chemical messengers. They're generally pro-inflammatory. These general pro-inflammatory messengers, basically one of them is TNF. So TNF is one example. Tumor necrosis factor is what that stands for. There's a variety of flavors of TNF that I'm not holding you responsible for. You'll hear about TNF alpha and TNF gamma, all these different tumor necrosis factors. But by and large, they are pro-inflammatory. And what happens is those pro-inflammatory cytokines cause capillaries to become leaky, right? That movement of fluid from inside of the bloodstream to the localized site of infection normally is a good thing, right? But it's that TNF, that pro-inflammatory cytokine, that's driving that inflammation. Does that make sense? So the TNF is a byproduct of your white blood cells responding to the presence of LPS.
So LPS is living in the bloodstream, so you have sepsis, and TNF is involved where you just see like the whole body just sort of up because of the inflammation, or is it more like
it's so if you are in septic shock, you're losing fluids to those leaky capillaries throughout your body. And so it's not like if I hurt my knee and my knee swells up, that's a localized area of inflammation. You don't have enough fluid in your body for your entire body to swell that much, right? But if the entire body did lose a small amount of water throughout it, that's where that hypotonic situation happens. So let me just show you. I don't know if this will help at all, but it'll only take a minute. So let's say this is a vein, okay? And within that vein, you have cells, and all I'm drawing here is a circle with an M in it that stands for macrophage, or in this case, since it's in the bloodstream, we'll call it a monocyte. And normally, what happens if let's say there's a bacteria out here in a tissue, what happens is cytokines and chemokines recruit that macrophage out of that site of infection. And the only reason that happens is because of inflammation. Right? There are cytokines that are telling this macrophage, hey, there's an infection here. And we're not going to go into the details of that process. Okay, but the difference in what happens when you have sepsis is that bacteria actually is in the blood, right? And the blood is circulating throughout the body. And so macrophages and other white blood cells all over your body are saying, we have an infection here. In reality, the infection's in the blood, but the macrophage interprets that as, oh, there's an infection, I need to get into the tissue to fight the infection. And so all of this fluid and cells escape into tissues throughout your body, causing you to become hypotonic. Does that make sense?
Yeah, that's
Very good. Very good. So that is endotoxin. Is there any more clarification that you need on endotoxin? And anybody from online, you need any clarification on endotoxin? Not seeing any questions. Okay. Good. The other half of this equation, if you have endotoxin, you have exotoxin. Right? So exotoxins are toxins that are secreted. Right? They start off at the bacteria, but they are secreted outside of the bacteria. Sometimes they can end up in the bloodstream. Sometimes they stay in localized tissues. What was the whole point of this? Why would a bacteria, if I'm a bacteria infecting your body, why would I produce an exotoxin? What do you think? Well, the advantage, or the example of the advantage that we gave in class was the bacteria that was residing in the GI tract secreted that exotoxin that allowed that bacteria to move from the lumen of the GI tract into the sterile tissue sites. Does that make sense? So normally, let's say this is the GI tract, and you have those nice little villi and microvilli, if we're talking about the small intestines. And normally what happens is, let's say this is the lumen, and then down here is the tissue, like the muscle and connective tissue, everything below that, okay? So on your apical surface here, on the top surface, normally these cells, these 4 separate cells of the small intestines, have tight junctions between them. They're waterproof. All right, so if you're a bacteria and you don't want to be in the, why don't you want to just stay in the lumen of the GI tract? Let's ask that question first. If you're a pathogen, why would you not want to, what's that? Well, depending on where you are, if you are in the stomach, yeah, you have acid, that could be an issue. If you're in the duodenum, there's some acid issues. That's good, that's one reason. Okay, so maybe the environment isn't quite right, especially when considering pH. Yeah, the other option is if you don't attach or somehow otherwise infect the body, you're going to get flushed through the body, and ultimately you're going to get, excreted, either through pee or through poop, right? And so from a bacterial standpoint, if you're a pathogenic bacteria, you want to establish an infection. Well, what some bacteria do is they produce these exotoxins, and some of these exotoxins, again, secreted into the environment. I'm just kind of drawing them up here as dots. What they do is they interact their toxins to those endothelial cells, and they literally cause these tight junctions to dissolve away, creating a breach in the barrier. So normally this is a nice waterproof barrier between the lumen of the small intestine and the tissue throughout the body. What happens is this exotoxin dissolves that tight junction, like I was talking about, allowing bacteria to move and then divide into that sterile site of infection. Alright? That's one example, just a general overview of how exotoxins work. Now, when we spoke about exotoxins, we spoke about 3 major different classes of exotoxins. 1 was your AB toxin, 2 was your membrane disrupting toxin, and 3 was your superantigen. Sound familiar? Very good. Now, how comfortable are you in distinguishing those from one another? If I say AB toxin, do you remember how that works? I'm seeing some yes and some no. So what I want to do is just talk about that real quick. If you remember AB toxins, all right, they have that A portion and the B portion. I usually draw them as a circle and a square, okay? The whole point of this is each part, the A portion and the B portion, does something. In this example, the B portion's job is only to bind to a receptor. All right? A lot of times when host cells bind to receptors, that receptor is going to have an action. In the case of AB toxins, that action is to internalize or phagocytose or eat that AV toxin into an endosome. Okay, and that's what I'm showing here, is that that cell has internalized or taken up the AV toxin. Now, normally what happens in a host cell is that a lysosome will fuse, a host cell lysosome will fuse with that endosome, and it will cause the pH to drop. When that happens with endotoxin and that pH drops, that link between the A portion and the B portion dissolves. And once that link between the A portion and the B portion dissolves, the A portion escapes into the cytoplasm of the host cell, and it goes and binds to the proteins or the Golgi or the mitochondria and has its toxic effect throughout the rest of the cell. But the whole point with the AV toxin is there's two parts, an A part, a B part. The B part's only job is to get this toxin internalized or taken up into your host cells. Then once the pH starts to drop, the A portion escapes into that host cell cytoplasm and has its toxic effect. Does that make sense? So that's category 1 of AV toxins. The second area or second type of toxin that we had talked about are called membrane-disrupting toxins. Okay, membrane-disrupting toxins, the one that we talked about briefly in class, were toxins that just disrupt membranes, right? That's what they do. That can happen one of a few ways. One is it could just dissolve the membrane away. 2, it could have this effect that we talked about earlier, where there's normally tight junctions between membranes that makes it leaky, allowing bacteria to infect otherwise sterile sites of infection. Those are the 2 main methods, or there's a variety of ways that they work, but membrane-disrupting toxins are going to somehow disrupt the normal histology, the normal anatomy of a membrane. Okay, that's how they're toxic. And then the third major class of exotoxin that we talked about was superantigen. What was so special about superantigen? So superantigens, again, if secreted by bacteria, are recognized by your immune response as a pro-inflammatory mediator. So superantigens is recognized as foreign and causes a pro-inflammatory response. Now, unfortunately, what happens here is usually these toxins have gone into circulation in the body, and they ultimately have caused they will cause systemic effects. So just like with endotoxin and LPS, you saw sepsis and septic shock because of the hypotonic environment. If you have a superantigen infection, your body is going to see that superantigen. It also is going to systemically become inflamed, and you again run the risk of going into shock, right? And I think I even listed off, shock as an option for superantigen. It's called toxic shock syndrome. All right, toxic shock syndrome is more or less equivalent to what you see with septic shock, where the patient becomes hypotonic. The key difference to remember, though, is that this is in response to an exotoxin. The body is not responding to the fact that you have the bacterial infection. The bacteria is not causing toxic shock syndrome. The superantigen, the exotoxin that the bacteria is secreting, is leading to that toxic shock syndrome that we're referring to. Does that make sense? So those were your major categories or classes of exotoxin. So we have endotoxin and exotoxin. Did you have any questions on either of those? And did anyone online have any questions? I'm not seeing anything so far. So does that clarify that a little bit?
Is the link between A and B just a sugar chain, or what is it?
Yeah, usually it is just a sugar chain between there. Some AV toxins have been known to have a peptide component to it, but not really usually. It's just a sugar linkage or a lipid linkage, which is a sialic acid. So, good question. I like that. Let's see. Now, another thing we talked about in class kind of related to this while we're on the topic was that, every time you get an infection with bacteria or viruses and stuff like that, you're not dying of things like exotoxin and endotoxin. That would be bad. But you do frequently get the pyrogenic response. What was the whole point of that pyrogenic response again? How did that work?
You got it.
You're up.
Put the bacteria in a uncomfortable
Yeah,
state.
like where they don't know anymore.
Good. So the pyrogenic response, so a pyrogen is any chemical that causes a fever. All right, there's tons of pyrogens, but any chemical that causes a fever. So technically, endotoxin or LPS is a pyrogen, right? Because if you are exposed to LPS, you're going to get a fever. Many of your exotoxins are pyrogens because they lead to fever. And again, from a body standpoint, what happens is your hypothalamus, right, is responding and producing prostaglandins that ultimately reset your homeostasis, reset that thermometer, and your body ramps up metabolism, raising your body temperature. And by raising your body temperature, you've taken your body, you're taking the bacteria, the infection, out of that optimal growth curve that we talked about. If you remove the bacteria out of its optimal growth temperature, it's not going to grow nearly as fast. And also, the second point of the pyrogenic response is that you've increased your body's metabolism, which means your immune system is going to respond more effectively. So it's a 1-2 punch. Your immune system has been ramped up, in addition to the fact that you have taken the bacteria out of its optimal growth temperature, therefore allowing you to better fight the infection. So, again, it's just important to realize that the pyrogenic response happens because of endo or exotoxins, but it is a distinct thing. Okay? Good. All right, so that answers those questions. What else did you come up with as you were reviewing the PowerPoints, reading the book, looking over your notes, looking at the study guide? Was there anything else that really stood up as, wow, this is something I'm not really comfortable with?
On the study guide, you have what is ID and how is it represented? What do you mean by how is it represented?
So normally, if you're looking at a chart in a hospital, right, and you know that this person has an E. coli infection, that's not just going to say ID, right? They're not going to say infectious dose. We talked about it in class a little bit. What's it going to say? It's going to say ID 50 usually.
Oh.
So ID 50 is infectious dose of 50, or how much bacteria does that person have to be exposed to that 50% of the population becomes infected. And we talked about what that means, and then how does that relate to Elding 50 and stuff like that. So, did any of that not make sense? That's what I meant. That's what I meant by that point. Yeah, sometimes wording is a challenge. Yeah, you'll normally see it represented as ID 50 on a chart. Anything else that was confusing or frustrating or not clear?
I guess like for the test, what kinds of questions can we expect to see, as in common pro vaccination groups? Like, will there be like teaching questions on it, or what kinds of?
Well, no. A common anti-vax point of view is natural immunity. So I can, ask you, what is natural immunity? How does it work? How does that go against, common vaccination standpoints? How does that relate to herd immunity, stuff like that? So, how is it different from herd immunity? I should say it that way. So,
do we need to know like the different laws on vaccinations for like California?
no, I'm not going to ask you in Washington, D.C. But it is important to know that you have those three major types of exemptions, right? You had medical exemptions, and that was because, some people, the immunocompromised, those patients who are severely elderly, severe infants, people that have had transplants, solid organ transplants, people that have had skin grafts, people that are just generally immunocompromised, they can't get vaccinated. So there are medical exemptions. Some people are allergic to the component that is used to generate the vaccines. So some vaccines are made in eggs. So if somebody has an egg allergy, they will, potentially go into shock if you give them that vaccination. So those are medical exemptions. The other category was philosophical exemptions. Those are the people that just say, I don't like vaccinations. And then the third major category were religious exemptions. I just want you to be aware of each of those exemptions and how do those play off. But I do not expect you to memorize which states mandate which requirements, because frankly that changes, like we had talked about in class about California. Good question. I do want you to know the different forms of vaccination. So if you were to give somebody a live vaccine, what does that mean? And again, have the appreciation of how much of a misnomer that is, right? To say that this is a live vaccine, it's an attenuated vaccine is the better way of saying that. But versus a subunit versus a conjugate vaccine. I want you to just know that those different types exist. I even gave you an example of a few of each of those as well. So, good.
What is an example of a conjugate vaccine? I was confused reading that.
A good conjugate vaccine is it's for elderly patients. This is a condition that elderly people get. Not shingles. That's the zoster. That's the zoster vaccine. I'm trying to think of it. Let's see if it comes to my head. But the yeah, but there's another one that's on the top of my head. My buddy studied it when he was doing his PhD. That's how I know it. But again, the take-home message about a conjugate vaccine is that you're taking something that the immune system does not react well with, like sugar, for example. If I were to inject you with a bunch of sugar, your body is not going to produce a potent immune response. And you conjugate it, or you link it to what's called an adjuvant, or something that activates the immune system. And the other advantage, and that tells the immune system, hey, I want you to make antibodies to whatever I'm connected with. The other advantage that I would point out is that with a conjugate vaccine is that you can give that vaccine multiple what are called valencies. That means you create antibodies to multiple different parts. So you'll find often when you get, for example, the flu vaccine, you are given immunization against multiple strains at the same time. Instead of given 10 different flu shots, you'll get one flu shot that protects you against 10 different strains. That's because you've taken components of those different viruses in this example and combined them into one vaccine. Does that make sense? So I want you to have a better understanding of what are the different types of viruses and know what that means, because you can always go look it up, right? You can Google, is pertussis whoopee cough, what type of vaccine is it? But if you don't know what the vaccine types are, that's not going to help you. So I just want you to know what the different forms of vaccines are, and what does that mean in terms of your immune response. I also want you to understand the basics of vaccine theory. We talked about vaccine theory and how does that work. We discussed that in class. Again, it's just important to have an understanding of the science behind how it works so you can best educate your patients. Good. Any other questions from online? I have not seen any questions here. I'm checking the chats. Nothing up right now. If you do have any questions for online, if you pull up the video link here on your YouTube channel, you'll have a chat section. Feel free to type away, and I will try to answer those questions. All right. Any other questions from the class?
We don't have to know the vaccination schedules.
No, you do not have to memorize the vaccination schedules. That's more there for you to just take a look at it and realize, because most people don't realize, when does a When does a newborn get their first flu shot? It's just kind of eye-opening to see those schedules and when they occur. Good question.
For the acronym TORCH, do you want us to know like what each letter means?
Yeah, I want both. I want you to know what it means, and I want you to know the general idea behind it. You know, if I were to come up to you in the hospital and I say, okay, we're about to go into room 212 here, and we're following TORCH protocol, I want you to have a general idea of what that means. Anything else? Is this helpful? Okay. Well, I don't see any questions online. I don't see any more questions from y'all. So, if anything comes up, let me know. I'm gonna go ahead and shut down the live stream if there's nothing else. Okay. Wait, you got one more?
Yeah, just like statistics with measles. Do you want us to know about that? Because I know you want us to know.
Yeah, there's the one slide there that says for each case of blah, it will lead to how many cases of others. I want you to know that I don't ask you to memorize many numbers. I am asking you to memorize that because I want you to know, if somebody comes in with pertussis, I want you to know that that one case is going to lead to, 12 to 18 other cases. That's striking. That is amazing when you think of one person infecting 12 to 18 others. Those 12 to 18 others are going to go infect 12 to 18 others. It is a beyond exponential expansion of this where you can literally start the day off with one patient, and by the time over the next few days, you just have an explosion of patients. It can overwhelm medical systems incredibly quick if you're dealing with an ill-vaccinated or an unvaccinated population. Even if you do have vaccines, again, vaccines are not 100% effective. The efficacy of vaccines, by and large, deals with the fact that we're relying on herd immunity. So yes, I do want you to know those numbers.
And then with measles, 1 in 4 hospitals, 1 in 1,000, something like this.
Yep. Yeah, well, it's especially with measles. We keep seeing these outbreaks. We just had it a few weeks ago, right, in the airports. Chicago Airport, 3 weeks ago now. I think JFK was the week before that, where we're having people come in. Usually it's on international flights, but you have people infected with measles going from Terminal 1 to Terminal 56, moving their bags and everything. You're exposing a lot of people to measles in that short period of time. So we keep seeing it pop up over and over again. And again, 1 in 4 people hospitalized. That isn't just, I'm going to go to the doctor. That is admitted into the hospital, taking up a bed. You're gonna fill up quick. And once Lutheran and Parkview and St. Joe and DuPont, once all those places fill up, what are you going to do? You're going to run into cases where people can't get care. Or they're going to go to our hospital, get exposed to measles, find out they're full, and then go, I'm going to just drive down to Indy. And what have we just done? We've transplanted that infection from Fort Wayne to Indy. All right, it can become a quite dynamic situation very, very quickly if this were to go unchecked. Good point. Anything else while we're here? Excellent. Well, keep up the good work. Study hard, and you'll have your exam either tomorrow or Wednesday, and we'll go from there. Sound like a plan? All right. Thank you all for coming out, and have a good one.